happy to join the medical student in this series of lecture in cardiovascular disease. Our lecture today title is the pericardial disease. Structure of the pericardium of two layers, composed of fibrous tissue mainly, inner layer and outer layer. Inner visceral layer called attached to that the epicardium, and outer layer which is called parietal layer. Its physiological functions stabilize the heart in anatomic position, protect the heart to contact with the surrounding structures, can be as a primary site of disease or involved in other disease process that affect the heart or affected by the disease transmitted from adjacent structures. The pericardium can permit a moderate change in a cardiac size. However, it cannot stretch rapidly enough to accommodate rapid dilatation of the heart or accumulation of fluid, with or without increasing intrapericardial or intracardiac pressure. Acute pericarditis is acute inflammation of pericardium. Origin or the causes could be infection, systemic illness, malignancy, radiation, drug toxicity, hemopericardium in trauma or the anticoagulations or bleeding tendency, other inflammatory process in the myocardium or lung. Pathological process often involve both, usually pericardium with myocardium. This picture shows that the acute inflammation with effusion of small amount of fluid and fibrin threads. If resolved completely, this fibrin thread will be absorbed and return to the normal. This is the gross appearance of the acute inflammation of the pericardium. Presentation and cause may be varied, depends on the cause. Syndrome often associated with chest pain, pleuritic usually, change with position. Dyspnea, pericardial friction rub with or without evidence of intrapericardial fluid accumulation or constrictions. Fever, leukocytosis are prominent. Viral infection, bacterial infection, fungal infection, or malignancy could be the cause behind acute pericarditis. The viral most commonly Coxsackie, B and A virus, and echovirus, also HIV virus, influenza viruses, Epstein-Barr viruses, varicella, hepatitis, mumps, bacteria, staphylococcal, streptococcal pneumonia, beta hemolytic streptococci, mycobacterium tuberculosis, and Lyme disease. Fungal infection and malignancy. Drugs can cause acute pericarditis like procainamide, hydralazine, and minoxidil. Radiations, connective tissue disease like lupus erythematosus, rheumatic fever, and rheumatoid arthritis. Uremia, also it's common in uremia. Myxedemia, post-acute myocardial infarction or post-cardiotomy, as we call Dressler syndrome. This we discuss, it's in a complication of acute myocardial infarction in the previous lecture, or could be idiopathic. Is the clinical feature sudden or gradual onset of sharp or stabbing chest pain like ischemic chest pain that radiate to the back, neck, left shoulder, arm, or trapezial ridge. Pain aggravated by movement or inspiration, or by lying supine. Sitting up and leaning forward usually reduce the pain. Associated symptoms will include low-grade fever, dyspnea, dysphagia sometimes, transient intermittent friction rub, here based at the lower left sternal border or apex. It is the most common physical and highly suggestive finding. Pericardial effusion, as the pericardium normally contains about 50 cc of fluid to make the movements and the easily lubricated. As the pericardium stretches, effusion that developed slowly, even large ones may not produce hemodynamic change. But however, if these appear rapidly accumulated, even small effusion can cause tamponade, Tamponade is elevated intrapericardial pressure more than 15 millimeter of mercury that restrict venous return and ventricular filling, resulting in a decreased stroke volume and cardiac output. Pulse pressure reduced and increased heart rate and venous pressure. Most common complaints, dyspnea and decreased exercise tolerance. Common symptoms, this is the subacute or chronic weight loss, pedal edema, and ascites. Physical finding is tachycardia, low systolic pressure, neuropulse pressure, pulsus paradoxus, neck vein distension, distant heart sound, right upper quadrant, abdominal pain. In acute pericardial tamponade, there is a peaks triad or peaks triology, hypotension or shock, distant jugular vein, and indistinct or distant heart sound, muffled heart sound. Subacute or chronic venous pressure increase, congestion of systemic circulation, cosmal sign, what mean dilatation, elevation of jugular veins during inspirations. Normally it descends, it decreases. Chest X-ray may show cardiac enlargement if enough pericardial fusion. ECG generalized ST and T-wave change. Characteristic progression ST segment elevation concave upward. Return to baseline. And the more characteristic is the PR segment depression. T-wave inversion non-specific, usually tachycardia. Echocardiography is important, often normal in inflammatory pericarditis, may show pericardial effusion. ST segment elevation in the acute pericarditis. Pericarditis with or without underlying cardiac disease doesn't typically produce this arrhythmia. It's not a major complication in the acute pericarditis. Chest X-ray usually normal, but should be done to rule out other diseases in the chest or mediastinum. Echocardiography, as we said, is essential in the diagnosis and exclude other causes. Other tests, complete blood count, differential, see infection, blood urea nitrogen if there's uremia, and creatinine, streptococcal serology, appropriate viral serology if indicated, other serology, antinuclear factor, and anti-double-stranded DNA antibodies, thyroid function study, ESR, it's important, creatinine kinase level with or without isoenzyme. This is the ECG of acute pericarditis, concave upward and PR depression. If we compare it with acute STEMI, ST segment elevation upward, this is upward of the inferior wall in lead 1, lead 2, lead 2, lead 3, and AVF, ST segment elevation, this acute myocardial infarction. And this is a chest X-ray. If the effusion enough, it's what's called water bottle, cardiomegaly and water bottle appearance. And echocardiography, if there is effusion, this is the short axis, and this is the amount of fluid, and there is a collapse right atrium. Viral pericarditis, most commonly caused by Coxsackie, as we said, and echovirus. Can also be caused by, as we said, HIV, influenza viruses, and other viruses. Most commonly affect males, age less than 50. Diagnosis usually clinical. Rising viral titer in paired sample or serum may be obtained for the confirmation of diagnosis. Cardiac enzyme may be slightly elevated, indicating myocardial component or involvement, and sometimes to differentiate it from the acute myocardial infarction. Viral pericarditis treatment, generally symptomatic treatment, aspirin or non-steroidal anti-inflammatory drug, corticosteroid if unresponsive cases. Symptoms gradually subside over several days to weeks, may be recurrent during first few weeks, months. Rarely patients suffer from a chronic recurrence, resulting in the constrictive pericarditis. Major early complication, tamponade, which is less than 5%. In a bacterial pericarditis, staphylococcal, streptococcal pneumonia, beta hemolytic, mycobacterium tuberculosis, usually direct result from pulmonary infection in the TB. Patients often present in a critically ill state. In the case Lyme disease, Borrelia burgdorferi, Borrelia burgdorferi, in the Lyme disease organism also can cause pericarditis. Rare in the developed countries in TB or TB pericarditis. It's common elsewhere, result from direct lymphatic or hematogenous spread. Commonly have associated with a pleural effusion and or small to moderate pericardial effusion usually. Or can cause a tamponade too. Subacute presentation, non-specific symptoms, fever, night sweat, and fatigue. Diagnosis confirmed if acid-fast bacilli found elsewhere. Usually therapy standard anti-TB therapy drugs, if not responding sometimes can add corticosteroid, and in some cases we need pericardiectomy if it's constrictive pericarditis. Complication if therapy unsuccessful, constrictive pericarditis. Complication of renal failure. This is the uremic pericarditis, occurs in the untreated uremia and even in a stable patient in a dialysis. Presentation with or without symptom, typically afebrile. Tamponade is common, usually resolved with the institution or remove or more aggressive dialysis. Pericardiectomy may become necessary in some cases. Indomethacin and systemic glucocorticoids ineffective in uremic pericarditis. Neoplastic pericarditis, commonly caused by breast and renal cell carcinoma, Hodgkin disease, and lymphomas. Neoplastic process involve the pericardium, are the most common cause of pericardial tamponade in many countries, second to that the trauma. Presenting symptoms related to the hemodynamic compromise of the primary disease process. MRI and CT scan is essential for diagnosis. Neoplastic pericarditis usually poor prognosis due to underlying malignancy. Prognosis poor, only small minority live more than 1 year. Fusion can be drained, chemotherapeutic agent, or that the tetracycline may prevent recurrent to produce fluorodesis. Pericardial window rarely effective. Partial pericardiectomy from the subxiphoid incisions may be successful in some cases. Radiation pericarditis usually occur within the first year after exposure, but can be delayed for many years. Symptomatic therapy, initial approach, but recurrent effusion and constriction require surgery. Post-myocardial infarction and post-cardiotomy pericarditis. Post-myocardial infarction, an inflammatory reaction to transmural myocardial necrosis that usually occurs in 2 to 5 days after infarction. Typically present as a pain, recurrent, audible rub, and repolarization change, ECG, ST segment elevation. Spontaneous resolution usually occurs after a few days. Aspirin, non-steroidal anti-inflammatory drug, symptomatic relief. While Dressler, as we discussed in the complication of acute myocardial infarction, occur weeks to several months after MI or, or open heart surgery. Presentation typically pain, fever, malaise, leukocytosis, and elevation of sedimentation rate. Large pericardial effusion common. Tamponade is a rare if a Dressler after MI, but more commonly seen in Dressler's post-operatively. Treatment is a non-steroidal of Dressler syndrome, non-steroidal anti-inflammatory drug, sometimes use corticosteroid. Recurrence is common. Chronic relapsing pericarditis, this entity occurs in a small percent of patients with acute idiopathic pericarditis. Steroid dependency requiring gradual tapering over 3 to 12 months. Non-steroidal anti-inflammatory drug, analgesics, and colchicine may be beneficial. Pericardiectomy for relief of symptoms is not always effective. This is few words about constrictive pericarditis, and we will discuss in details in other lecture. Is a constriction occur when a fibrous thickening and loss of elasticity of pericardium result in interference of diastolic filling, usually following inflammation. Cardiac trauma, open heart surgery, this is a major cause, intrapericardial hemorrhage, and fungal or bacterial, especially TB, pericarditis, uremic pericarditis are the most common causes of constrictive pericarditis. Symptoms of constrictive pericarditis develop gradually and they mimic those of the restrictive cardiomyopathy. Congestive heart failure, exercise dyspnea, decreased exercise tolerance, chest pain, orthopnea, and paroxysmal nocturnal dyspnea are uncommon as in the restrictive cardiomyopathy. Pedal edema, hepatomegaly, ascites, JVB elevated, cosmal sign. Increased JVB with inspiration. Pericardial knock, early diastolic sound heard at the apex, usually no friction rub. Diagnosis: ECG may show low voltage QRS complexes, inverted T-wave. Chest X-ray, 50% of cases show pericardial calcification, which is very essential, important in the diagnosis. Doppler echocardiography is essential. Cardiac CT or MRI sometimes used to show the thickening of the pericardium. Consider other disease: acute pericarditis, myocarditis, exacerbation of chronic ventricular dysfunction, or systemic process, example sepsis. Treatment of the constrictive pericarditis: generally supportive care, initial treatment, symptomatic patient, pericardiectomy, diuresis use, but is a gentle, and treatment with the appropriate antibiotic if indicated. Restriction and versus constriction pericarditis, in similarity, as we say, in the clinical presentation, but history provide can be important clues. Constrictive pericarditis, history of TB, trauma, pericarditis, collagen vascular disease, this is a collagen, and this is a collagen vascular disease. Restrictive cardiomyopathy, history amyloidosis, hemochromatosis, and the mixed, both of them, if the mediastinal radiation and cardiac surgery. And in the constrictive and restrictive, constrictive pericarditis and the restrictive cardiomyopathy, this pattern see in the angio, the same dip and the plateau, or what called square root. This is the square root or dip and the plateau. Both of them show this in the angiography. And this is test, you can follow it and the answer is test 1, which is the second most common cause of adolescent sudden death, and which of the following is not useful in a cardiac tamponade, and you can say in the answer which of the following is not a sign found in the ECG of acute pericarditis, and number 4, which is not a sign or symptom of acute pericarditis, number 5, which is not one of 4 types of common cardiomyopathy classes. Thank you for the active participation.